Hello, everyone, and welcome to another edition of the SEANC View podcast. I'm your host, Jonathan Owens, the Communications Director at SEANC, alongside Artis Watkins, the Executive Director, and Sammy Klein, our podcast producer. Suzanne Beasley is not with us this week, but we do have our fifth Beatle in the house.
Hello.
Thomas Friedman from the State Health Plan, Executive Administrator of the State Health Plan, has been so kind to join us this week and talk about all things State Health Plan related. I think we'll just take up the whole episode with Thomas since he's such a good interview. What do you think, Thomas? You up for that?
I'm here for whatever y'all need, whenever y'all need it. I'm the fifth Beatle, right? I got to get to four.
Well, it's a great time to talk about the State Health Plan with the legislature returning to session April 21st, I think.
Mm-hmm.
Yeah. And obviously, there's going to be a lot of talk about the budget, and a big part of that is the State Health Plan, right, Artis?
It shouldn't be an either or, whether the state funds the state health plan appropriately so that costs don't have to get shifted to members in terms of increased premiums, et cetera, or they can have a pay raise that's anywhere close to keeping up with inflation. But that's the way some people in the legislature look at it right now. We've been hearing a lot of that if we have to fund the health plan the way we're hearing we have to fund it, then we're going to have to dial back on what we give in terms of raises or anything to retirees. And that's not fair, number one, because employees and retirees can't control the health plan's costs. And I know we got a lot of other things to get into, but I do want to say this. For years, back in the day, we would have folks who were participants on the board of the health plan actually say out loud, these state employees cost so much money, as though we were sicker or more negligent, as though we ran to the hospital every time we got a slight headache. And that wasn't true, but that was thrown out there a lot. And what we don't want to do is go back to those days of misinformation in terms of usage and or utilization, I guess y'all call it in the biz. But I do think there's people who just feel like this healthcare is costing too much. It's these employees. And it's not.
Healthcare does cost too much because healthcare costs too much.
Yeah.
The costs of healthcare is too much. We definitely understand that. I don't disagree at all. And we're actively working to drive the cost of healthcare down. And the cost problem is we pay too much for healthcare problem. I feel very confident. We've been consistent in our budget requests from the legislature from last year. We try to be good partners. I'm very, very confident things will work out for a budget perspective. But the responsibility to reducing the cost of healthcare is 100% on the state health plan to do going forward. That's explicitly my job, and we recognize we have to be the ones driving down costs. I think Lantern is a good step in the right direction there. Mm-hmm. And I think there'll probably be some more questions about that a little bit later, but it has really been a big catalyst for change. But healthcare didn't get broken overnight. We're not going to fix it overnight. We, the Treasurer and I think we believe investing in the long-term ability for the health plan to be sustainable, to keep it affordable, so we can start pushing costs down is what we need to do in the next couple of years. And we're going to tackle it really hard.
So we're definitely going to talk about Lantern. There's been a lot of news recently about it. Before we get to that, let's talk a little bit about what the State Health Plan Board of Trustees did at their last meeting. They make the decisions for the plan, right?
Yes. Yeah, I would be happy to. So it was a good and interesting meeting. I was more excited about it, and it probably seemed a little operationally a little dull, but it was something that I was really excited about for a couple of reasons. So something we learned from the Clear Pricing Project, where I want to give Treasurer Falwell a lot of credit, is our members are extremely sensitive to price, kind of going back to pay raises and salaries and healthcare being too dang expensive. Obviously, folks are sensitive to price on things. And so that was one of the lessons we took from the Lantern program, which has been extremely successful. I really want to thank SEANC's engagement for that. Y'all are the drivers of that. So we said we need to double down on that and making providers compete for state health plan business. So Lantern surgeries are free and there are preferred providers. How do we make everything else cheaper in a sustainable way? So we didn't really have a mechanism to allow providers to compete for our business, right? Because if you have a regular copay design, it's $15 to go to Duke, it's $15 to go to UNC. It's kind of cost agnostic to the person, so they don't realize that underlying price is really, really different. So what we've decided in investing in is we're going to have providers we prefer, where it's going to be materially cheaper for the member to go there. I think we can blow past affordability on the 2012 benefits, making it materially cheaper for folks to use that. And why I think that, and when we're having conversations with health systems and practices about this right now, because one, their first ask was, you say you're going to do this, be able to make it cheaper for members to go here. show me you can do that. And that's what the board approved, is our ability to make a low-cost tier, a middle tier for like our more rural and out-of-state folks, and a non-preferred tier.
Gotcha.
So, you know what the first thing the providers who want to be in the preferred network say to me? How cheap can you make it for your members to come here? That is what they're asking. That is the steerage they want. They say, we recognize we need to see more people. How much more affordable are you willing to make it? And that will drive their discount, right? So they are thinking of the member first, because they recognize it is the member's behavior that is going to drive this and help them be successful. I wouldn't have told you I would have expected that to happen
Never.
24 months ago. But the folks we're working with, that's their focus. How affordable can you make it for members to come here? And not just copays, it is deductible out-of-pocket costs. It is, if you make the out-of-pocket cost half of what it is now, we'll give you a better deal. If you make the deductible half of what it is now, we'll make it a better deal for members to come see us, because that's how members are going to make decisions. And that is really exciting to me. I want to pause, and we're really starting there in the 3 kind of urban areas of the state, because that's where there's more competition. And I think about that as the triangle, but mostly Wake County, the triad kind of all over the place in Charlotte. That's a lot of our spend, but that's not a lot of our membership. A lot of our folks travel for care. So we wanted to make sure there is an access tier. Folks, we want to encourage folks to travel for care. If they're not Lantern, we're going to pay for it. But we also want to support local independent providers the best we can. They're generally speaking not the most expensive providers. So we're going to have a middle access tier that, if you thought about 80% of the counties in the state, we're just going to make it a little bit more affordable to stay where you are from a care perspective, and kind of drive that change. So if you can stay in your community, we can help them build sustainable models to be really excellent at something. And we want to get 90% of our members using those 2 tiers of providers.
What does that mean for me, though, if I live in Plymouth, North Carolina, or somewhere considered rural?
Sure, yeah. So if you're in Plymouth, North Carolina, next year your benefit is going to look either the same as it does right now, or a little bit better than it does right now in kind of certain areas. We got to see what we can afford. We're kind of in the negotiation dance of things. But I don't want to punish folks in rural communities by making their benefit worse. And that's why we had to go to 3 tiers, right? It's because we have to have better, where there's not competition. We can't punish that. We can't punish you for living in a rural community. I can't make more providers show up, but I can't just implicitly charge you more because of where you choose to live. And then in those more competitive geographies, if for the systems and large ambulatory surgery centers who don't want to be a part of Lantern, who don't want to provide a better deal, it is going to be more expensive for members to go there.
Gotcha.
Because we use preferred very carefully. We prefer you go to these providers and you will save a tremendous amount of money. The plan will save a tremendous amount of money. So that is what the board approved, the structure to do that. And so now we are working with some of our partners to figure out how good of a deal can we get to cover the state of North Carolina. And that will continue to evolve over time. What I like about this model is it can continue to grow. As folks want to continue to give us a better deal, we can continue to make it cheaper for members, and we don't have to wait to January 1 every year. And folks have reached out and said, hey, we're not part of this Lantern thing. We're not part of this. How do we get to be a part of it?
You mean providers?
Providers.
Oh, good.
Because they're losing volume. They're losing business. And it's like, well, this is what you got to do. Here are the steps. And I think about this as kind of further. If you're losing hospital volume because you made it more expensive for members to go there, I'm happy to accept a better deal. I'm more than happy.
Well, that's kind of the point of the Lantern, right?
Yeah.
I mean, to introduce some competition. So
yeah. So it is a different way to think about it. But the crux of it is, and I'm glad our partners get it, I'm sorry about my hands. We have to reward members first at the point of care. This does not work if the member doesn't get the best deal at the point.
Okay, but we've talked about this a number of times. People are so suspicious of anything different, and I get that. But here we are. We were just talking about it, John. How would you boil this down in terms of, we know you're suspicious, but?
Yeah, I think one thing I've noticed a lot from our Facebook comments is people are afraid of what they call steerage. You heard of it? Like, you're making me go to this provider, or you're steering me to these folks.
Mm-hmm.
How do you address that?
Well, I would say I'm not making you.
Yeah.
We are going to keep everyone in network who wants to be part of the network. One of the challenges of traditional healthcare designs, and I think Treasurer Falwell was on this early, is that prices aren't transparent. So your copay, let's say for a specialist, is $50. For you, it's $50. You don't know if the state health plan's paying $250, $550, $950. It doesn't make a difference to you, and it's too hard to figure out.
Yeah.
So the folks that are going to go in that higher cost tier, they're the ones who are charging you more money every time you go. Part of being in our preferred provider program is you're going to get our members in faster. You're going to commit to higher quality care, and you're only going to be rewarded and allowed to stay in if you deliver high quality care. So I appreciate the skepticism, but if it costs the state health plan 2 to 3 to 4 to 5 to 6 times more for you to stay with your provider, you are going to have to pay a little bit more. But we are going to do everything we can to have more lower cost providers.
Yeah.
I've talked to a handful of members the past few months that they're sick folks that they're like, I'm hitting the out-of-pocket max of $16,000 every single year.
Yeah.
We are going to get that out-of-pocket max down for that preferred tier by several $1,000s.
Yeah.
That it's not a raise, but if you're paying $5,000-$6,000 less a year on healthcare.
Well, back to by your point's well taken. Back to how we started this. If the General Assembly is saying, look, the health plan costs us too much money, so we can't give you much of a raise, it's affecting everybody's pocketbook at the end of the day. So I'm all for steering people towards, encouraging people to go to providers who are competent, but give a fair deal to the state. And it's a choice. Nobody's forcing anybody. So don't take the choice if you don't want to, but don't be mad that the choice is out there. I mean, when y'all have had some pretty big players in terms of providers join in. So if you want to elaborate on that.
If you think about the big providers that have joined the Lantern Network.
Wait 1 second. Let's explain Lantern, because I feel like a lot of people on our Facebook page still don't understand how you can offer surgeries for free.
Great. Yeah. And I'm sorry, I start going.
I did too. I jumped right in. We talk about it so much, we feel like it's old hat.
And so Lantern is something we continue to evolve the framing on. So Lantern is our partner for you to call to get higher quality, lower cost care. They are not doctors. They are the folks that get you to those doctors and help us negotiate those deals. So who you're getting care from are places like Emerge Ortho, Novant. Ortho Carolina is a new partnership we're rolling out. UNC. Those are providers that have been delivering healthcare to state health plan members since before any of us were alive. And they've stepped up and said, we recognize the value of state employees and we're going to give you a better deal in exchange for making it cheaper for members so we get more volume. So Lantern isn't cutting anyone open, I promise you. And it's not every doctor at these practices, and not just anyone can get in the practice. It is folks that do these surgeries a lot of times, but it's with the doctors you're going to right now. And something I think is really, really important along those lines is you don't have to do this, keeping the surgical options open, but we recognize surgery is expensive, it is complicated, it is scary, and it is hard. Asking you to shop for a surgeon when your knee's killing you or your back's killing you or you need bariatric care or you need heart care, that's not fair. That is not a reasonable ask to be like, hey, on top of everything, go online and look at 58 different doctors for the best price. The nice thing about Lantern is that they will help get you to a provider who has agreed to take a significant discount to deliver that care. We pay them faster. We don't do prior administration. They get more volume because it's a better deal for them. And that's how we can offer. It is not a free surgery. I assure you, I sign checks every single day for surgeries.
It's free to the member.
It is free to the member because we save so much money. And the only fair thing to do when we are saving money on a surgery or a procedure is to reward the member first. And I can't go cheaper than free right now.
It's the how you save money part, I think, that still confuses people.
So I'm looking at the board materials from the board meeting, and this is a pretty cut and dry example, and it's probably not, it doesn't get into the details, but let's say that a provider wants to charge $30,000 for a surgery. So that would be that the plan would pay $25,000 and the member would pay $5,000. But if you can use a Lantern provider that will charge $15,000 for that same surgery, then the plan would pay $15,000, the member would pay nothing, and the plan still saves $15,000, right?
$10,000, I think.
Yeah. I'm not good.
Yeah. But so we save money. The member saves money. And again, you got to go back to, if we're expecting folks to behave differently, we got to give them the incentive. It's their surgery. It's not mine.
Yeah. But it's not free because, hey, we want you to go to these places and then it'll be free for you because these doctors are questionable. It's free because these massive healthcare systems you
Yes.
just mentioned, and hopefully many others, have said, we want your business.
Yep.
And so we're willing not to rip off the state health plan. We're willing to give a reasonable deal, and we hope we're going to get big volume out of that. So it's not free because it's lesser than.
Yeah.
But I kind of wonder, and this, leaving you out of this, Thomas, because the health plan's not part of this. But when we get these comments, John, sometimes they're members, sometimes they're not.
Yeah.
And sometimes I wonder when people are throwing rocks at it, are they real people?
Sometimes you can see a trend among the
Yeah.
like the steerage part that I saw. I saw several comments that were using that language. So
Yeah,
it
that
seems
doesn't
like-
sound like your average state employee that's interested in this issue. So, in other words, if I did not want to give a good deal, I might have interest in piping up and trying to poo-poo ideas like this.
Yeah.
That, look, we've even been, it's even been said to us, y'all are being too cozy with the state health plan.
You give me a hard time all the time.
I was going to say, no one's going to be harder.
Yeah.
I feel like in just a factual way, hopefully, and just putting issues out there to be talked about. But no one's going to be harder on y'all than us. However, in addition to saying what we've said before, you can't say no to everything and then expect everything to get paid for at the same rate. But also, they're trying something at the state health plan, y'all. So if you're a state employee or retiree hearing this, when the state health plan is making a concerted effort that does not do anything to diminish the quality of your care, it's a voluntary choice, but it would save them so much money, their ask of the legislature is less. There's more money there for you as a state employee or retiree to get something given to you to keep up with the cost of living. It's not there if the state health plan's soaking it all up. So what these folks are doing is saying, we've got to try to bring people to the table. Right now, the law prohibits them from saying, here's what we're paying everybody. Y'all can look at it and you can throw rocks at the providers that are charging us too much. The law prohibits them from doing that. So they've had to get creative, and this is their answer. So, yeah, you're darn right that we're cozy with you about doing that because it's doing something.
Yeah. And I was looking at this one comment here. So the comment is, so you have to go to have your surgery 2 or 3 states away? Like, who wants to do that? And then I looked at the profile, and it was clearly AI type pictures and things. So I wonder if there is a concerted effort to take down. Have you seen pushback like that?
We have seen pushback in a few ways, and some of it is fair. Some of it is reasonable. Not every provider wants to deliver high quality care at a lower cost.
Mm-hmm.
So some folks are going to have to travel more. And that is a fair criticism. If you live by yourself, if you don't have help, you might not be able to access it right away. But we have to start. And I will tell you, the providers who aren't in are feeling it right now.
Yeah.
And they want to get in. And you got to start to get to the next place. So we will continue to grow the program to provide higher quality options. And let's pretend that statement is true. You got to go 2 states away for care. That means someone in North Carolina, no doctor, no health system, no surgeon, was willing to give a good enough deal that we couldn't save more money sending someone there. That's not a critique of me.
Yeah.
That is a critique of the system and the pricing of the system. And willing to pay for your flight and your hotel if that is the best deal possible for a complex care with a high quality provider. That's my job, is to make sure you get that and to make it as affordable and as seamless as possible. But this thing needs to build on itself.
But you built it more than I thought you would, actually. I honestly wondered.
You were very skeptical the first time we talked about this.
I wondered how many providers would do it. I really did. I thought they would just freeze you out.
Yeah, it takes one to start. Because I think they had to feel the pinch. And I'm grateful for Lantern, who brought in a network. I'm grateful for Novant and Emerge, North Carolina, to make a bet, right? Because as the folks that are calling now are the folks that lost volume, are losing volume. And they're talking to their friends. And that's how we get more. We got lucky that we had good partners and y'all and good partners in the provider community to jump in with both feet to try something different. And that's how it's going to grow and get better. It is not perfect. It is never going to be perfect. The U.S. healthcare system has got its not without a share of problems, but we are going to continue to push and make it better and better and better for state employees. And because that's my job and that's the right thing to do.
Let's talk briefly about the success that you've had. I'm looking at the presentation. It says you've had 1,848 cases as of March 4th.
Mm-hmm.
That's pretty amazing for a program that's only been in place, I guess. Well, you launched it in October, right? But
We launched in October, it was small, and that number is before Novant joined. That is before all of Emerge Ortho was in. We're at running about 4 times higher than I thought, multiple of 4 of where I thought, and probably 10 times higher.
Again, I'm shocked. I honestly thought that they would successfully freeze you out. So kudos to y'all for having faith in it and for being diligent about it to just not let that happen.
Well, thank you for that. And what's exciting is I think, we've also heard from smaller hospitals and independent practices, how do we get in? I think we chatted last fall, we had kind of a procurement process for the big, and that's how Novant kind of got to win, how UNC has gotten to win in some areas. We're going to go back out to some of the smaller systems and some of the smaller entities, give them a chance to engage. They still got to give the same deal. They've got to deliver the high quality care, but that's how we're going to get more providers in. We're really going to capitalize on that momentum and be very clear. These are the rates we're expecting. It's not the 160 Dale Follow asked for. It's not the 200% some of these bills asked for. It's less than both is our expectation on these things. And I talked to the heads of 8 hospitals yesterday throughout the state. They're all interested in engaging. They recognize quality as the front door. To your point, we're not taking a surgeon who's done these things 3 times. We want your best providers at the practice.
Because you have to pay for it later.
That's
if
right.
it's not a good surgeon and there's complications.
That's right. I don't want to pay twice.
Right.
And then the member has to pay to go through surgery twice. And that's not fair.
Yeah. And you'll hear about that.
Yeah. So we're going to continue to build and roll this out to try to bring it into more communities. And an ask of members, I would ask you, advocate if your provider's not in and they're telling you I'm not in, woe is me, y'all have another bite at the apple.
Yeah.
Get in.
Be a member, right?
Right. We would gladly have you if you can deliver high quality care at a fair price to state employees. And if they want to continue to charge state employees more for care, you can keep going there. But that's what's going to be driving up premiums in the future, not the other side of it.
Rural healthcare has been such a problem across the board in terms of making sure there's access for folks, more than making sure it's affordable a lot of times. But I know that the vast difference in what some providers were being compensated in terms of a percentage of Medicare as a reference point.
Mm-hmm.
Some of them were so low and some of them were so wildly high. But my understanding was the low ones, a lot of the times, those were in rural areas. So is there not a possibility that being with Lantern with this program, it could actually help rural healthcare?
100%. Thank you for yes, that is the value proposition we're offering, right? You might be able to make actually a little bit more money. You might get a lot more volume and folks can stay closer to, and you can grow your program. It's also an economic development thing for somebody. If
exactly.
Get really good at it. And something the treasurers challenged me to do directly is right now, 70-80% of care drives to urban communities for care. We got to make some services excellent and help support other services being excellent all throughout the state of North Carolina to help the local economies, but also to create centers of excellence so those health systems can be more viable.
Right.
We don't need them to be the best at everything, but let's pick a few things, get really, really good at it, and we can steer our state. I'm going to use the word steer because I think it's the right word. State employees there for low-cost free care.
Well, and that was one of the things we did like a lot about the idea of the Clear Pricing Project is that some of those kind of underpaid providers would be able to still stick around. And it sounds like you've got that covered.
I think so. And, we heard loud and clear from primary care that they wouldn't be able to be sustainable without the rates from the Clear Pricing Project. So we put those back in effect for primary care, assuming they could we put some requirements around it. You get state employees in. You help get them to those lower cost options. You continue to deliver that high quality care. You have better access for them.
That's fair.
We recognize we're happy to give you more money, but it's not free money. It's a partnership.
Yeah.
So if you're an orthopedic surgeon in, say, Plymouth, North Carolina, you could rack up with all the people in the East, right? I mean, you can.
If you're doing a good job delivering high quality care and you can deliver it at a price that is reasonable and fair to state employees, absolutely. There's no reason you can't.
You can draw all
a lot of folks in that northeastern part of the state go up to Norfolk, don't they?
Yeah.
I would prefer they stay in North Carolina, but we got to give them a better option, right? There's some really good healthcare delivered in the southeastern part of Virginia. There's great healthcare in the northeastern part of North Carolina too, And we got to help them amplify what they're doing and make it attractive to go there. And talking to folks, I think they're very willing to do that. We just got to focus. And I don't think anyone's really engaged them to say, I need you to be really good at this thing. I am going to have thousands of people in your local counties every year for now in perpetuity. State government's not going away. DOT's not going away. Prisons aren't going away. Police officers aren't going away. Schools aren't going away. We can help you grow. AI is not taking those jobs quite yet.
We were speaking to some police officers a few weeks ago, and there was, there's interest in trying to, as there is in anything else, in trying to find ways to bring healthcare costs down. And they're not, obviously, they're in, for the most part, in their local systems. Some local systems are part of you, though, right? Like how many locals are now in the state health plan?
We have overall 456 different units.
That's a lot.
There's a lot of schools, a lot of charter schools, ABC. We range from, HHS to charter schools to ABC stores in some towns. But we're better together than apart. And we're all in this together. So if we can partner with those systems and have that mentality of like, we want you to be successful, but we need you to invest in us too. That's how this all works together is we want you to be a hospital here forever. We want people to have high quality local care, but it's got to be high quality. It's got to be at a reasonable price and folks got to be able to get in. If you can do that, the state employees are more recession proof than any other job, right? We're not going to not have corrections officers. We're not going to not have DOT. We're not going to not have all of these folks work for the state. They're committed. They stay at their jobs longer.
Yeah.
Correctional officers, there's not going to be like a little AI robot replacing them. And they deserve high quality, low cost care in their communities. So we need health systems, providers to think about this as a partnership that we can do together. Let's grow together. Let's improve health together. Let's improve health outcomes together. And let's improve our businesses together.
Do you feel like you're leading the way without intending to? You're trying to take care of the state health plan because that's y'all's job. But does it ever occur to you that it might be leading the way to helping North Carolina out of that number one costliest for healthcare position? Because if you're 1/10 of the commercial market, and you bring costs down, you're going to move the market a little bit.
I sure hope so. And that's the treasurer's point of view, right? Is we got to bring everyone along together. I'm going to give him all the credit for that, not me. But yeah, that's how we do this, right? Is if it becomes a competition on price and quality, rather than racing to the highest price, you're going to race to the most critical pool of patients that can help you. That drives costs down. That helps folks get more efficient. That helps them think about site of care differently. Something I think that was, having worked at a health system, I think about a lot, but is like probably not intuitive to everyone. If you have a surgery at a hospital, the cost of the surgery is higher because the rent's higher, the cost than if you have it at an ambulatory surgery center or a doctor's office. There's just more stuff going on. Doesn't mean it's a better surgery. In a lot of cases, it means it's a worse surgery. Not in a lot of cases, but it could be the case. So why don't we get that surgery to the safest place it can be where it costs the least? Because I'm going to pay you the same amount of money one way or the other. This is the amount of money you're getting for the surgery. You can make more money if they all get more efficient and you're going to get more volume.
Let's go back to the cases that you've had already. And this may not be available and it may just be anecdotal, but what is the response of people who have gone through Lantern so far? Have you had many complaints or any big success stories you can talk about?
We're working on some videos of success stories right now because we have had quite a few success stories and the people are really excited. I think the frustration we have seen is around having to travel for care, which I understand. It's a newer program. The costs are zero, so I haven't had too many concerns about costs quite yet. But I think the biggest concerns we've heard is having to travel and it takes a long time to schedule care. Healthcare takes a long time to schedule care. That we're getting you in much faster here. So I think that when you need surgery, you want it now. You don't want to wait any amount of time. And I get that. And I think that's a perfectly reasonable complaint, but just know we're going to continue to push it forward and drive it forward.
Yeah, we've had a few comments on our social media about folks who have gone through it and they've been excited about it. One person said their son is about to do the same, that she had surgery and now her son is going to do it too. So it seems like it's successful.
It has been. And the more word of mouth we can get, right? Like kind of go back to a few premises. Like people don't trust insurance companies. They shouldn't. People trust me maybe like a little bit more. People trust their doctors pretty decent, but they trust the people they work with. They trust their friends. And so the more, positive word of mouth we can get on this from our members who have had a great experience, that's what folks are going to listen to and believe in, right? Because you can hear some bureaucrat like me talk about stuff forever, but when your neighbor does it and works out for them, I think that probably hits home a little harder.
And I think that's right. That's what I was getting ready to mention is that I saw this chart about and by the way, this chart this comes from the Bureau of Labor Statistics. So it's a real thing, not just something somebody's trying to, some propaganda. But anyways, it shows from 1970 to 2015, the growth of physicians versus administrators of hospitals, the executives, not the people actually giving you care. And from 1970 to 2015, the physicians only grew by about 200%, but the number of administrators grew by 3,000%. So I think, therein seems to lie the problem.
I think that's a big part of the problem. I think the other problem, and maybe it's part of the same problem, I'm not entirely sure, is no one's challenged them on cost before. Negotiations like, well, the prices go up. Or we go to value-based.
It's complex. Y'all don't understand.
Yeah. And, having been on the other side of this coin, I think maybe not fully, but I understand maybe a little bit. And healthcare has a cost problem. We, as a health plan, haven't tackled the cost problem, the cost of healthcare. And I think folks are trying on the provider side to tackle the cost problem, but they got a lot of work to do too.
Well, but I can't buy that when, in terms of, it being a cost problem in terms of it's just very costly to provide this care.
No, that's why they haven't looked at it. I don't think they've done a good job looking.
And the way if nothing else, is the sheer volume of advertising they do. And knowing how much that costs, it's like, no, you're fine. You're absolutely fine.
I don't think the treasurer would mind me sharing this, but his point of view is the more celebrities you have in your ad, the less interested he is in doing their drug.
By the way, we keep saying the treasurer. For folks who aren't regular listeners, the treasurer of North Carolina is Brad Briner. This is his first term, second year of his first term. And so Thomas reports directly to Treasurer Briner because Treasurer Briner's office of the treasurer has the state health plan under its umbrella of duties.
And the state retirement plan.
And all the things really that are the most important to the state employees and retirees. But we want to echo what Thomas said, thank you to Treasurer Briner for taking this so seriously and allowing you to dig into it.
It's been great for his direction. I think his point of view is we have to be more efficient. We have to do a better job. There's too much opportunity to not try some stuff because the current model is not working for anybody. Providers are burning out. We're paying too much money. We're not getting any healthier. Why would we keep on keeping on? We've got to realize the value in the healthcare system is the patient. And we should be every other part of life, we compete for customers by creating the best value proposition for customers. We need to make healthcare like that. There should be nothing more valuable to healthcare providers than state employees.
And there should be nothing that has had such bipartisan support for secrecy like there is for healthcare pricing. But there traditionally has been a completely bipartisan effort to keep us from knowing. And so I think that tide seems like it's shifting a little bit.
I think so. I think we're moving in the right direction. Slowly, not as fast as I'd like.
Because it's hard to go home and explain that you don't think the people should know.
So do you have anything else you want to talk about in the state health plan realm before we get to the fun stuff?
No, so we covered Lantern, the next round of procurements there. We covered the benefit design. It's really grateful for y'all. I think, we're not out of the woods on the kind of the deficit we inherited, but we're moving in the right direction. We're moving to get costs down for those who want to partner with us.
Oh, I know one thing we need to talk about briefly. So the news that you're not going to re-sign with Aetna and you're going to put the contract back out to bid, that caused a lot of comments on our social media.
Yeah. The contract runs for 25, 26, 27, and there's 2 optional extensions. It doesn't mean Aetna is not going to be our TPA in the future. If you think about, and they both have their strengths, if you think about Treasurer Falwell, and you think about Treasurer Briner, and you think about the previous executive administrator, pretty different points of view on things. And I want to give kudos to the previous administration for a lot of things they did. A lot of things, though, I don't agree with. I believe in value-based care. I believe in population health management. And so we want a TPA contract that reflects the values we're bringing to things here. So I don't think of it as any sort of way other than that. It's just.
Do you believe in value-based care, or is value-based care not even really the thing anymore that y'all are doing? It seems like it's morphing, right?
So it is morphing into the value is the member.
Right.
And I believe we do have to invest in population health, but we got a lot of fat to cut on the prices first. And that's the money we're going to use to invest in those things rather than asking members to pay more money. Let's get the money out of providers first and get their incentives aligned, right? So just a different value set. There's no reason that Aetna can't win and be the TPA there, but we just thought, why continue on something that isn't...
Can you tell us what you'll be looking for, or is that getting into stuff you can't get into?
I think what we're looking for is, and I've said this publicly, so I don't have a problem saying it, partners that are really focused on helping us execute what we want to do. And that previous RFP was different folks, what different folks wanted to do, right? Like, that's not a critique of anyone. We want to prioritize things like population health, patient navigation. The system is too hard and too complicated. And getting really strong patient navigation, someone whose incentive is to get the patient to the right place, not an insurance company, not the state health plan, someone whose job is to get the patient to the right place for them and understands things, to be a patient advocate. Those are the things we are prioritizing. If it's not clear, like I'm a little bit of a control freak and I like a lot of flexibility, and I want a contract that reflects the state gives me pretty broad latitude in state law. The executive administrator's got a lot of responsibility. I also want a contract that refleceks that, right? I think that those are important to me.
And with pharmaceuticals, especially, I know you you came out pretty strong that you didn't want to overpay for those.
We do not. And similar, at the same time, we have our RFP out for our pharmacy benefit manager that is also going to start 1/1/28. So we are trying to move to contracts that better reflect our values. We're not necessarily saying we're going to change, but the contract terms have to be about aligning our incentives.
You have to look at it.
It's our job to look at it.
So as you can see, the state health plan is a huge, huge, sprawling spider of
as important
topics.
as anything in somebody's life. Right?
Yeah. So you could have your own podcast. I think I told you that last time. You need to start your own, because you could talk about this every week for an hour.
He's busy trying to get people to...
I got to do the doing.
Well, thanks so much for coming in, and you're actually going to help us with our question of the week.
Okay.
I don't know if you knew that or not, but you're going to.
I'm old hat, a fifth Beatle, so...
Okay. Play my theme song.
John's wacky weird question of the week.
So it's a pretty simple one this week, and I've already asked you. So, well, kind of in a roundabout way, but who's going to win the national championship? And I ask you because you got to set that up. Now.
Yes. So I went to the University of Arizona, and I'm from Tucson, Arizona. So I am a Wildcat through and through. Bear down, Arizona. I'm very hopeful we win the national championship this year. I'm equally as hopeful that UNC does not take our basketball coach. That's in the ether there, that they really interested in Tommy Lloyd. Treasurer Briner is big UNC fan.
Oh, okay. I knew I liked him.
And yeah, me too. So I've begged and pleaded with him, like, y'all, let us keep our basketball coach, but Arizona through and through.
You got to be pretty proud that you have somebody that everybody wants, because he is probably the hottest name in all of coaching. But
I think so. If you didn't watch the game, he... First thing he did was give the players a lot of credit, and he gave credit to a former Arizona coach who passed away a couple years ago. And just, he's a leader by leading and giving credit where it's due, not taking it. So I am very hopeful he sticks around Arizona for a long, long time.
So I can go next, because I hate to say it, but I think that Michigan will probably win, because I've watched them all year, and they're just very talented, very big.
Look, they're always lurking around there towards the top.
And they have a former Tar Heel in Elliot Cadeau as their point guard. So. But I think I'm pulling for Arizona just because I want Coach Lloyd to win a championship there and then come to Chapel Hill and finish out his career.
No, we'll probably hire somebody who won an NBA championship as a coach like 20 years ago.
Is that a Belichick reference?
We're just making some choices. That's all I know. We're just making some choices.
So you've been away. Have you been paying attention to the games?
As long as it's not UConn, I'm cool, because Hurley, I cannot.
See, I kind of like him.
Oh, goodness, I cannot.
He's like in on the joke, though. He's not like, I don't know. I think
his brother coached at Arizona State, which is University of Arizona, and that fool couldn't keep his head up. Right.
Well, we had to deal with him when he was a player. His brother. Yeah. They've got a lot of passion, but the Hurley family.
So you're not making a prediction other than you don't?
No, I wouldn't know what to predict right now, honestly.
Yeah. What about you, Sammy?
Was I supposed to be paying attention to this tournament? Because I haven't.
To basketball?
Yeah, I don't know.
Oh, okay.
Western Carolina's not in it?
Yeah. All I know is I don't want UNC to win, because I'm still mad at y'all for taking our best football player.
Yeah. So
Had one good season.
Probably left us after one too, so don't worry about it.
so that's our episode for this week, and we'll see you next week.